Film start అయిపోయింది. హలో హలో చెప్పాలి. గుడ్ మార్నింగ్. కాలేజ్లో చెప్పండి. Yeah, I'll call you. Good morning. I think we have done with acute osteomyelitis. If you remember, then there was a break for 1 week. Then here we are again. And this time we will continue with our chronic osteomyelitis. I don't know whether somebody has taken it in the intervening Saturday, but anyway, I think you don't mind me telling it again. So chronic osteomyelitis is a continuation of the acute type of osteomyelitis. If it stays say for more than 6 weeks, a unwanted, unwelcome guest who overstays his welcome. Here there is recurrent attacks of infection characterized by you find a persistently discharging sinus. So a bone which is involved, all of you know that the infection is centered in the metaphysis in the acute phase, and it can go anywhere. We have told you about the various routes it can take, and once it becomes a chronic osteomyelitis, the picture will be something similar to this. Here you find pus, and at the same time there will be a new bone formation. It's the nature of the bone that whenever it is stressed, and mind you, infection is one of the stressful conditions for the bone as well as for us. So whenever bone is stressed, it forms new bone. So this is a new bone here, and the medullary cavity, the dimensions of the medullary cavity are decreased. So it's more or less a closed cavity. An open cavity is amenable for increased blood supply and chance for antibiotics to reach that area. But once something is closed, so if the society is open, then you are open for suggestions and there is chance for any change. But if it is a closed thing, then no new idea can enter, or the old ideas can go out of the system. So it should always be an open system. Likewise, even here, once the medullary cavity is closed, then the infection is walled off. In a way, this is a protective thing, but infection stays here. So decreased medullary cavity, and which leads to decreased blood supply to some parts of the bone, and such bones become dead, or they are known as a sequestrum. So the cavity filled with pus or discharge, which tries to come out through persisting sinus. So this is the pathology in chronic osteomyelitis. So this is the X-ray wherein you can see a new bone formation, and this is the cavity, and the usually open medullary cavity is closed for most part. So all these things constitute to make chronic osteomyelitis. So etiology commonly follows acute osteomyelitis. So why should an acute osteomyelitis be chronic? If the treatment is not instituted properly at the earliest, or if the treatment is inadequate, then definitely the acute can turn into chronic. And if a drainage is done and part of the pus is not evacuated, I told you in the beginning of last class itself that once a bone is infected, it stays infected. Likewise, as and when the patient's immunity comes down, or when the treatment is inadequate, then definitely it flares up. It flares up and it persists, and an acute infection can turn into chronic osteomyelitis, and it stays. It stays. Once it comes, it will never go. The severity may be different. If the treatment is effective and the patient's immunity is more, then definitely infection will be reduced. But a few organisms will definitely lurk in the nooks and corners, and as and when conditions become ripe for them, they resurge and definitely cause florid infection again. So these are some of the things which will flare up acute infection and make it into a chronic variety. The pathology, as I told you before, there will be a dead bone in between the new bones which is being formed all around the dead bone. The dead bone is because of the decreased vascularity, and it's called sequestrum. So this is the dead bone. This is called sequestrum. So very, very touch sensitive. This is sequestrum, and this is the cavity surrounding the sequestrum. So sequestrum always will be in a cavity which contains discharge, usually purulent discharge, because the commonest organism is Staphylococcus aureus. So the purulent discharge try to find a way out. So this is the sinus through which the pus or discharge which is there inside the medullary cavity of the bone tries to come out. So nature has a tendency to send out unwanted dead material. So it doesn't want to keep them inside forever. So this sinus keeps on persisting till the last dead vestige of the chronic osteomyelitis infection goes out. But bone cannot do everything on its own. So you need to help the bone to do this natural process. So you find a persistent discharging sinus on the skin, and because of that chronic infection, the bone becomes irregular. So because there will be new bone being formed and a part of the bone is being removed. So all these processes will make a thick irregular bone at the side of the sinus, and sometimes the skin which is overlying the bone becomes adherent to the bone and it becomes a discolored skin. So the skin is discolored, becomes adherent to the bone, and the bone is irregular and persistent sinus. These are some of the clinical features. Whenever you examine a patient of chronic osteomyelitis, all these things are seen. So this is the sequestrum, and how to identify sequestrum we'll see. So when a piece of bone comes out, or when you do a process called sequestrectomy, you take out this piece of bone. You don't know whether this is a normal bone or the sequestrum, because sequestrum appears dense on the X-ray, but once you take it out, this looks like any other normal bone. So how to identify a sequestrum from normal bone? Sequestrum has two surfaces. One is outer surface, one is inner surface. The surface which is inner, which is in contact, or the surface which is in contact with the fluid, that is the pus or the discharge, will become irregular. So rough. So this surface which is on the outside of the sequestrum, because the sequestrum is floating in a fluid of the discharge. So fluid all around the outer aspect of the sequestrum. So the outer surface is rough, but the inner surface is smooth. So if you find a bone piece with these two characteristics, then you can safely say that it is a sequestrum, and you have multiple holes in the bone. So that is the sinuses, various sinuses which help the pus to go outside body. So a sequestrum has two surfaces. one rough outer surface and smooth inner surface, and bone has multiple openings. Coming to the radiological features, here once you see the bone, there will be increased periosteal reaction. So the periosteum, which is irritated, forms more and more. Whenever the periosteum is lifted or irritated, then what it does, the only thing which it can do is to form new bone as a insurance policy against loss of bone. So there will be thickening of the cortex will be there. Thickening of the cortex will be there, and the new bone which is being formed is known as involucrum. And this involucrum has a lot of holes as a drainage method through which the pus which is there inside the medullary cavity finds its way out, its nature way of drainage. So the holes in the bone will help the pus to come outside through the persistent sinus which opens onto the skin. So this is the mechanism by which bone tries to get rid of its waste. So the involucrum is all around the sequestrum, and the sequestrum is very sclerosed and it appears dense on X-rays, but it's a dead bone. So clinically, as a patient comes to you, so you need to search for these things. Patient will give a history of acute osteomyelitis. He says he was he had, if he is intelligent, he can say he had infection of the bone, or he can say he had lot of pain 1-2 months ago, and severe pain and fever, and patient had to take injections for so many days, and patient was not able to use the limb for so many days, and he went to XYZ hospital and ABCD doctor treated him with this, that, so many things. So history becomes very, very important. And when you examine the patient, what you can find is the discharging sinus. The sinus is still intact, and there will be discharge. Patient may be dressing the wound depending upon the amount of discharge which is there. So if it is more discharge, more of it is being pumped out, then he may have to dress it 3-4 times a day. But if it is less and patient's immunity is taking over, maybe once in 2 days or 3 days he has to dress the wound. So patient gives a history of from that time till now I am saddled with this problem, doctor. There is a discharge which is foul smelling, so I cannot mingle with the crowd. I am not able to go to my college, school, or whatever. I am unable to play my games because there is fever, pain, and a blood comes, and once it breaks and the discharge comes out, then I feel better. So he gives the history of these things, a repeated history, and you find a thick and irregular bone when you palpate, and skin, as I told you, it may be adherent to the bone, and there may be some discoloration, and most of these things happen in and near the joints as infection is colonized in the metaphysis, which is very, very close to the joint, because the epiphysis is end, which is the lower or upper ends, and it takes part in the joint formation. So this is very close to the joint, and if you are not using the joint because of the pain, then over a period of time disused atrophy or stiffening occurs and joint becomes very, very stiff. So you need to make the patient start mobilizing the joints as early as possible in most of the orthopedic problems. That is one thing which an orthopedic surgeon should always tell the patient, because movement is life. So if you don't move the joint, if you don't use it, you will lose it. That is our dictum. In orthopedics, we believe that if you don't use a joint, you are going to lose it. So always we treat them energetically so that the patient can go back to his original evocation. So we see to it that the joints are not stiff, and patient bone is not normal and it becomes weak. So even a trivial trauma can injure the bone or may lead to a fracture. a trivial trauma causing a fracture in an abnormal bone. That's quite common. And a fracture occurring in an abnormal bone is called a pathological fracture. Normal fracture needs some amount of force to break a bone, because breaking a bone is not normal, and you need a lot of strength to do it. But if the bone becomes abnormal because of some other underlying pathology, the commonest being infection, or sometimes they may be tumors, so these weaken the bone, or sometimes nutritional osteoporosis. So all these things make bone weak. Once the bones become weak, they are liable for these pathological fractures. Sometimes when the sinus is not so prominent, the pathological fracture is the one with which the patient may come to you. So as you see the patient and go back and do your investigations, then the infection history comes out, or the findings you can find much later. So pathological fracture can be a presenting symptom or sign, and there may be a periodic flare up as and when the infection flares up, because the immunity comes down. Then there will be swelling, pain, tenderness, all these things, all the signs of inflammation will be there. And this is called an acute flare up of chronic osteomyelitis. Usually chronic osteomyelitis is quiescent, but it becomes angry, acute. When does it do that? When the patient's immunity comes down, or a new superbug which is not sensitive to any of the known antibiotics, it mutates or something happens, then definitely you will find these acute or chronic osteomyelitis episodes. So the commonest investigations which we subject the patients to is an X-ray. And in this X-ray, what usually you see is, this is the outer cortex. It is thickened, and there is a new bone formation. This is something like a sleeve on the outside, okay, outside the main bone. So this is because of the irritation or the lifting of the periosteum. So as I told you before, whenever it becomes irritated, then it results in new bone formation. And not only that, inside you can see this is a dark areas, that is, there are so many cavities inside, okay. And this is not continuous cavity. This medullary canal has walled off sections. Some sections are walled off, and there are cavities in some other areas. And if you find it a thick sclerosed bone inside this cavity, then we call that as a sequestrum. And as all of you know, sequestrum has two surfaces, a rough outside surface and one smooth inside surface. Rough outside because of the contact with the granulation tissue, pus, all the other discharge and debris. Inside it is smooth. So if you find a piece of bone floating in the cavity, and you find these two different textures on both the sides, then you can safely say that it is a piece of sequestrum. And involucrum and cloacae. Involucrum is the new bone which is formed, and cloacae are the multiple openings in the new bone. They are called cloacae. And sinogram, maybe you need to resort to sinogram sometimes to delineate the path of a sinus. In general surgery, you get to read the sinogram. So sinogram is a procedure where you inject a dye at the external opening of a sinus to see the path, extension and internal opening of the sinus. So here, suppose if there is a sinus here, from here the pus is tracking outside. So this is the sinus tract, and this is the opening on the skin. So if you inject dye here, then the dye will find its way back into the medullary canal. So this whole path can be clearly delineated once you take an X-ray after injecting the radio contrast dye. So this is called a sinogram. So this is done to know the exact location and extension of the sinus. So when you want to excise this sinus, you need to excise the whole sinus tract. If you don't excise the whole sinus tract, then it will recur. So that's the importance of doing this sinogram. So sinogram is a injection of contrast material from the sinus opening outside till the inner opening. Usually these sinuses, perianal sinuses will be there. So that is also one place in gen surgery you get to see. And sometimes there may be chronic ulcers which may have this sinus. So chronic discharging ulcers apart from chronic osteomyelitis. So these are some of the places where you get to do this sinogram. Coming to the differential diagnosis. So whenever you make a diagnosis, it's always prudent on you to just think this, what else it could be. So don't think that just because you made a diagnosis, it is the diagnosis. Never. So you should always need to consider conditions which are very similar to our provisional diagnosis and why this is not so. So you made a diagnosis of chronic osteomyelitis, but there are some other conditions which can mimic this chronic osteomyelitis. So you need to know what are those conditions which can mimic chronic osteomyelitis, and you should know something about those conditions, and because of which you can differentiate between those conditions and chronic osteomyelitis. So because you need to differentiate, this is known as a differential diagnosis of for every condition. So even in the exams, even if you know the definitive diagnosis, because most of the times all the PGs or assistants, they'll come and tell you in the year the definitive diagnosis. So you don't bother whether your diagnosis is correct or not. We in the exams, what we see is how do you arrive at the diagnosis. So we don't expect you to make, we don't expect you to be Newtons or Einsteins. So we expect you to be a scientist who thinks rationally. So once you make a diagnosis, what are the various things you considered from the history? See, from the history, you need to pick up some points, some positive points and for some negative points to arrive at a diagnosis. And at every step, you have to recheck your diagnosis. Then only you will arrive at the correct diagnosis. So this is how you should learn the clinical subject. So then you will never go wrong. See, the beauty is not making the diagnosis somebody tells you. So how you arrive at the diagnosis by taking everything into consideration. So here the other specific types of osteomyelitis, so tuberculous osteomyelitis which we have seen, so that could be one of the differential diagnosis. Tuberculosis, you will have different findings because a patient may be having a primary focus somewhere, or patient will have decreased body weight, decreased appetite, so many things all of you know, things to consider the patient to be of tuberculous origin. So other important thing which you need to consider as a differential diagnosis and which is very, very important in this clinical clinical diagnosis is Ewing sarcoma. Ewing sarcoma is one type of malignant bone tumor, usually occurs in children. And as you know by now, even the acute osteomyelitis is very, very common in children. And as you know, chronic osteomyelitis follows acute osteomyelitis if the treatment is not proper. So in a child, if chronic osteomyelitis is there, so you should always have Ewing sarcoma at the back of your mind. So could this be Ewing sarcoma? So all the things you will be considering, all the investigations you are doing, and you should be guarded in your prognosis till you do the definitive diagnosis before you tell the patient that nothing is the problem, this is only infection or something like that. So you should have this Ewing sarcoma at the back of your mind. Unless you have an inkling that it could be Ewing sarcoma, you may not be able to make a diagnosis of Ewing sarcoma. So if you miss an Ewing sarcoma and treat it as chronic osteomyelitis, I think you are making a grave. You should be in another profession. As simple as that. Okay. So Ewing sarcoma is one of the DDs, that is differential diagnosis. You should never ever forget while making a diagnosis of chronic osteomyelitis. It could be any other long-standing soft tissue chronic infections, even bone. above bone there are so many soft tissues which may have a chronic ulcer infection. Tubercular osteomyelitis we already discussed. Coming to the treatment, see what is the treatment? So for every treatment you should have an aim. So what is the aim here? See why this persistent sinus is still present. So the sinus is present because it wants to push out the dead bone which is there inside the medullary canal. So sometimes it may break the bone into small pieces and they push it completely, or sometimes it may get walled off and become integrated and new bone may form if the immunity is very high and antibiotics are working. Then you otherwise you need to help nature by manually removing and making a drainage procedure there. So if you can help the bone to drain better, so then as and when the debris is collected, it is pushed out. So there are one or two surgical procedures which are very important and which we'll discuss it here. All of you know, whenever you are drinking chai in Irani cave, and by the way, don't try to do it because recently there was a news item to say that they are mixing this animal bone powder in this Irani chai to make it more thick. So they take, all of you know that 1 liter milk will be made into maybe 1,000 cups of tea. Yeah, you can add as much amount of water as you can. Then tea becomes very thin. Then they add this animal bone powder. You get it for nothing, next to nothing. So you can find these animal bones lying anywhere around, and they just bring it, grind it, and add to your cup of Irani chai. So don't drink it and tell your friends not to drink it because that may damage your health. So there they'll supply the chai in a cup and saucer. So if you are sharing it with your friend, what do? You pour some tea in the saucer and give it to him. Or if you are in a hurry, you want to catch a train and you just had that hot cup of chai, you don't want to waste it. Then you pour some in the saucer and you blow on it and start drinking. And the moment you pour that hot tea onto the saucer, then because of some physical laws, most of you know better, then because of convection of the heat, then it becomes cool. Then you can drink it much faster. So what is happening? We do a procedure here very similar to that. So the cup is a deep structure, and to drain from a cup is very difficult. So if you can make a deep hollow, a deep hollow into a shallow structure by cutting the edges. See, this is a cup and they cut these edges. Once they cut the bony edges, it has become more or less shallower and wider. So this is a narrow mouth here, but it is very wide and a bit of shallow one. Then the drainage is much easy. So this procedure is called saucerization. So you make a deep crevice into a shallow one and opening is much wider. So this is saucerization. Once you do the saucerization, it is very easy for you to pick up a this dead bone which is lying there in the cavity. That is called sequestrum, and removal of sequestrum is known as sequestrectomy. As simple as that. So you have two procedures. One is saucerization, or sometimes in some textbooks it's known as a gutterization. So the name itself indicates that you are trying to make a gutter. All of you know what a gutter is. So whenever in olden days, I don't know how now whether they have it or not, whenever the water has to flow, they make a small gutter so that water flows from the roof onto the soakage pit or something like that. So this is a passage for the water to flow. So that is a gutter. So if you can make a gutter from the inside of the bone to outside, then that facilitates that discharge to come out onto the surface. So saucerization or gutterization or drainage procedures, and sequestrectomy is the removal of the dead bone. So these are some of the procedures which you do in chronic osteomyelitis. One more thing which we do is we have what is known as curettage. What you do is you curate the inside of the medullary canal. You put some instrument here and take out all the dead and devitalized tissue and make it into a clean cavity. Once you do that, you take out all the dead pieces of bone and necrotic pieces of bone, soft tissue, everything you take it out. You make a window into the bone, and under vision you can do all these things. After you clean the insides, then what you do, you put a tube inside. On one side you put a tube for sending the fluid in, and on another side you put a fluid to collect the fluid. So indwelling, this is known as continuous suction irrigation system. So suction irrigation system, you send a fluid inside which is going into the medullary canal, and it fills up the whole canal, and this fluid contains antibiotic solution. So the antibiotic for which the organism is susceptible is added to the IV fluids, and it is sent, and once the whole cavity is filled, you leave it for some time. Once this is all filled up, no more fluid enters because of the laws of physics. All of you are very familiar with those things. Once the pressure inside and outside becomes normal, then no movement of fluid will be there. So that fluid will be there inside for some time. Keep it for some time. Then it comes in contact with the organisms which are lurking in and around that area. So there will be local action, and all the antibiotic goes and fights against the bacteria and kills it. Then what you do after, say, around the contact time is over, this is called a contact time. Every organism or every bactericidal substance or antibiotic, if it comes in contact with the bacterium, it should be a minimum time and a minimum concentration. MIC and contact time, they are very important. I think you get to know about these things in microbiology. So once that contact time is gone, then you drain it under suction. So you drain the whole fluid from inside the bone. You collect this. Then this becomes empty again. Then this fluid again fills up the cavity. So you should keep this on for maybe around 24 to 48 hours. Once you do this, the insides of the bone are thoroughly clean. Already you have done curettage. You have already removed manually everything macroscopically, and microscopically you have instituted this suction irrigation antibiotic solution. And sometimes there is another procedure called antibiotic beads. Most of you know that Hyderabad is very famous, and it is otherwise known as Pearl City. So because pearls are very famous, that means a lot of varieties of pearls are available in Hyderabad. If you go to Charminar area, there are a lot of shops, and you can buy throughout the day. It may not be enough for you to do the shopping. So these pearls, all of you know that they are white, round, and they are a bead. They are in a beaded like structure. So what we do is we add antibiotic to a bone cement. We have a substance called bone cement. Bone cement is different from routine Nagarjuna or Rasi cements which you use for construction of the buildings. Bone cement is to strengthen the bone. This is a chemical compound, polymethyl methacrylate. So this bone cement, we mix the antibiotic and we make it into small beads, and we string them on a steel wire, and you keep that inside the bone. You keep that inside the bone, then the antibiotic oozes out of the beads. I'll show you these pictures in the next class. Then you will understand. But till then you remember that there is another procedure called antibiotic beads. If you remember Hyderabad, Pearl City, Charminar, then definitely it will spring to your mind that there is some procedure called uh, beads, antibiotic beads. So that antibiotic beads can be kept inside the cavity wherein the antibiotic oozes in, and there will be local action. You can give whatever amount of IV antibiotics, but the amount which reaches the site may be very less. But if you give local antibiotic, the effect can be manifold. So these are some of the procedures. One is sarcorization or gutterization, then sequestrectomy, or then you do curettage and excise the dead bone and institute what is known as continuous suction irrigation. So these are some of the treatment modalities you need to apply in chronic osteomyelitis patient. So you need not do everything for every patient. See, that's where the beauty of our medicine is. Medicine is not like buying a ready-made shirt. One size fits all. No, my shoulder is 42, I go and buy 42 size, it fits me. It's not like that. Sometimes what happens, 42 is a bit tight for me. If I go for 44, then I will be like a clown. So my size is somewhere in between. So what I used to do, I used to get it stitched for myself. That is a custom made one. But unfortunately, that system has gone out of the window nowadays. But in medicine, that is coming back. So every patient is different. So there is nothing like one size fits all. No, we do according to the patient's needs. So tailored to the patient's needs. So that's the buzzword now. So learn this. See, tailored to the patient needs. Not it's not right nowadays to say that one size fits all. So these are the procedures. You need to select which one to do for what. So depending upon the patient's severity and the condition at which he comes to you, you pick up. If there is a sequestrum, then only go for sequestrectomy. If there is no sequestrum, just because you have read or you have attended my class, don't try and go do sequestrectomy in a patient where there is no sequestrum. Understood? So these are some of the mechanisms by which you can these are the things which you can offer to him, and you select a method which is best for that patient. That's all this is about. Coming to the complications, if you don't treat this patient, what will happen? So if you don't treat a chronic osteomyelitis patient, or if the treatment is not effective, then there will be these recurrent acute episodes. Patient may be fine for, there was no fever and all for 2 months, but suddenly there is an abscess which bursts and suddenly patient will have fever and all. So acute episodes intervening in between a chronic course of the disease are quite common. That is one of the common complications. Or sometimes if this infection is in and near the growth plate, which we have seen in acute osteomyelitis, it may involve or it may be all around the growth plate. So if the infection is overwhelming, then there will be shortening, because that growth plate is not able to function to its full potential. So there will be stunting of growth. Or if it is a subacute infection which merely irritates the growth plate, then the growth may be more. Sometimes as a periosteum which is irritated will lead to new bone formation. Even a growth plate when irritated may lead to new bone formation, and the limb may be bigger or taller than the corresponding normal one. So patient, either way, patient will have limb length discrepancy. This is called one limb being short than the other limb, or one limb being longer than the other limb. So this is known as limb length discrepancy, which is very it's not right, it's pathological actually. So if the limb is not right, then patient has to modify his gait. Then definitely there will be changes in the pelvis, there will be changes in the spine to correspond to that modification. So we'll see to it that there will not be any of these things with our proper and prompt treatment. And as all of you know that there could be a pathological fracture. Pathological fracture maybe sometimes is the presenting complaint with which the patient comes to you. And joint stiffness is quite known. And important one is amyloidosis. Amyloid material can form inside a chronic irritating chronic osteomyelitis ends up in amyloidosis. Amyloid material, all of you must have read about this in your pathology days. So this amyloidosis is a very, very problematic complication of chronic osteomyelitis. And one more important complication is this malignancy, which can occur in the sinus tract. So this because of the chronic irritation, anywhere chronic irritation is there, then the body mechanism goes haywire, and there will be more and more formation of particular type of cells, and which may go overboard and which may result in some malignant tumor. So the commonest malignancy which can occur in the sinus and sinus tract is a squamous cell carcinoma. Fortunately, its prognosis is quite good, and these are some of the complications which are very, very important. That's why you need to identify the chronic osteomyelitis. The moment patient enters your chambers, you should be able to have an idea that this could be a chronic osteomyelitis and do the relevant investigations, get all the x-rays and all, get this culture and sensitivity, and know the organism which is behind this, and do a good job. Then you won't need to see these complications. And chronic osteomyelitis, as the name itself says, it's not very simple for you to treat it on day one itself. No, I have several patients. I'm treating them for so long now, maybe 10 years, 15 years, because for 2 to 3 years they are quite happy. They even go abroad and come back. But because the bone, once infected, will always be infected, if they are not careful about their diet, or so many things can go wrong, and they may end up having this acute exacerbation. And patient comes to me, sir, again the discharge is coming, sir. My new Armani suit was spoiled because of the discharge or something like that. So these things have to be, you should have patience, and even the patient should have patience. So this can be an ongoing process, and you should explain everything to the patient in the first visit itself. Once the patient can understand his disease, then his acceptance will be easier, and once the patient accepts, then treatment will be much, much easier. So you should take the patient into confidence and explain everything to him. Then definitely the treatment will be much effective, much more effective. And as I said, it may take years to come out of it. And very rarely, you may need to take out the limb, that is amputation. But the indications are very limited. That means a patient who is positive, he doesn't want, nobody wants to lose his natural limb, and neither you suggest to him unless it is. See, you may come to a stage where you need to choose between life and limb. When you come to that crossroad, then definitely you need to take the road for life. Life is more important than limb. Then you should tell the patient that if you don't take out the limb, then you may lose your life. That is the only indication where amputation should be considered. Usually patients come to you, sir, there is disfigurement and there is lot of pus coming out, and I need to dress it 3-4 times, very inconvenient, and I am very much foul smelling. My girlfriend is not with me. So many things he will tell you. So he wants you to amputate it, but never ever do it for those flimsy reasons. So you should convince the patient to have the natural. See, whatever you do, so it won't be natural. But nowadays we have so excellent prosthetic limbs and all. So even people are running in the Olympics even with those prostheses on. So it's not that but whatever God given is definitely natural one, and you should try to preserve it for as long as possible. But if it is grossly disturbing the patient's psychological makeup or his physical daily activities, then definitely you should consider uh, resorting to amputation. And never ever think that by offering amputation his life is over. No, actually his life begins from then on. So you need to make the patient positive even after amputation, and he can have a fruitful life with all the negativity gone. See, no need of dressing every day. So you should tell him on positive aspects of not having the limb, not having a diseased limb. So everything is in your hands. How you make the patient ready for any procedure, you want the best for him. Always you try to have the best for him. So always patient comes first. Once the patient recognizes that is your attitude, then definitely patient will cooperate with you. So this is something about chronic osteomyelitis, why it occurs, how it occurs, what are the clinical features, what are the investigations you need to do, and what is the pathology, and how do you go about treating, and what are the various procedures you have, and what are the complications, and what are the advices you need to give to the patient. So this is about chronic osteomyelitis. This is a very, very important topic, both for theory, and if a case is there when your exams are going on, then definitely that will be kept for as a short case. So read about this, learn everything about chronic osteomyelitis, and next time when you see someone on the street, then definitely, if possible, make friendship with him and take some history and see how you can help him better. Okay, thank you very much. Let them decide and let them change themselves. I think what? Correct.
Hmm.